You guys, so today we're going to be going over step 3 in our 5-step approach or 5-box approach to leveling up your first aid care and capabilities. Step 3 is going to be bleeding control and trauma care. Now, the way we like to organize a lot of this is that the first 2 steps, or what we call our boxes that we've created or come up with to organizing the tasks and things you need to do to level up your care capabilities and really organize the tasks that you need to accomplish between identifying a first aid situation and getting that person to a higher level of care. We've implemented these boxes so that you can be organized in that approach and be efficient in what you're doing. The first 2 steps, essentially, which we'll link to up here, being that mindset and leadership, and then step 2 or box 2 being your situational awareness and actions and safety. Those are more of the cerebral thinking through things, kind of that prepare accordingly, knowing that you've prepared to help keep you cool, calm, and collected in that situation. When we get into boxes 3, 4, and 5, or steps 3, 4, and 5, those are actual hands-on care, once again, provided it's safe for you to step in and do that. So with bleeding control and trauma care today, we're talking about life-threatening bleeding control and trauma care. So with bleeding control, we're looking at bright red, which it may not always be bright, but some other things we're looking at are spurting and spraying blood, pooling blood on the ground or wherever it's at, very saturated clothing or dressings that we've applied and it's not stopping. So essentially we start with that direct pressure and it's saturating the dressings, the towel, whatever we're using to stop the bleeding, along with pooling blood, spraying blood, spurting blood. And regarding that pooling, typically once we see about a cup or half a soda can's worth of blood, that volume on the ground, which is about this much blood or a little bit more, we're really looking into or towing that line of life-threatening bleeding. So we want to use some of the tools that have come from combat situations, in wilderness situations, just situations here in America and around the world, honestly, to control that bleeding. So some of the tools or equipment we'll use with bleeding control are tourniquets, compression dressings, wound packing, and chest seals, which we'll get into those. And then with trauma care, we are looking at what's considered what you call your mechanism of injury. And the mechanism of injury is it's simply that which caused the injury. So if we have a broken arm from somebody playing soccer, it's a ground level trip and fall. The mechanism is very low. It's simply a ground level fall. Now, another fall, which would be considered a greater mechanism of injury and possibly lead to a life-threatening traumatic injury, would say a 20-foot fall out of a tree. So it's a greater mechanism. When we're looking at traumatic injuries or trauma care in our basic first aid, we're considering the higher level of mechanism. So a car hitting a person at a high rate of speed, or a person running into a car typically on a bicycle at a high rate of speed, high level falls or impacts with blunt objects that are going to result in life-threatening injuries. And those are going to be exemplified, or we're going to see the signs or hear the symptoms of those by evaluating a person's mental status. Are they thinking clearly or not? We're looking at their skin condition, color, and temperature, and some other things we'll get into. So life-threatening bleeding control and life-threatening trauma care are box 3 and step 3. Once again, the boxes or the steps are simply ways for you to organize the tasks you need to work through in order to fight for a solution when we get that person to a higher level of care. Remember, we want to identify that a first aid situation has happened, and we want to manage that person, that situation, those people until a higher level of care gets to us, or we can get them to a higher level of care. That time period in between those 2 points can be very chaotic. And with life-threatening trauma care and bleeding, or life-threatening trauma and bleeding, it's extremely stressful. So once again, steps 1 and 2 or boxes 1 and 2. Box 1 was mindset and first aid, mindset and leadership. 2 was first aid, situational awareness, actions, and safety. Those are more of the academic or the prepare accordingly type of, I can think my way through the situation, I've prepared for the situation, kind of the prep for that situation. Boxes 3, 4, and 5 are going to be your hands-on care, once again provided it's safe for you to put hands on and take care of that person. So there's a saying or an algorithm or a guideline in the military and the fire department, and it's changed with time. They're perfecting it all the time. Different first aid companies and individuals are adding to this algorithm, but that algorithm that's used to orient somebody in a combat type situation is called the MARCH algorithm, M-A-R-C-H. And that helps to organize your priorities to make sure that you're affecting the best possible care for that person. And that would be M is massive hemorrhage, A is airway, R respiration, C circulation, H is for head injury and hypothermia. Now, like I said, there are different variations of this. For me, for my family's first aid, and in the basic first aid arena, and for families and non-professionals that I've stepped into, I like to add on to that. And the way I like to organize that is what's called SE marches. So SEMARCHSSS. And it's an algorithm that once again, I'll just go back to it, that when this happens, it's going to be very stressful. So you need a way to organize your thoughts and your tasks so that you can stay cool, calm, and collected. Remember, once again, we're not going to rise to the occasion. We're simply going to fall to our systems, and that place where we spend time preparing for any type of situation should happen. So in order for you to truly manage a life-threatening traumatic situation or a life-threatening bleeding situation, you need to have prepared accordingly before, and there are specific tasks we need to get through in order to affect a better outcome. So getting into it, once again, bleeding control accounts for, I think it's about 35 to 45% of pre-hospital deaths. So uncontrolled bleeding, 35% of people who die from bleeding pre-hospital could have been saved, possibly been saved with bleeding control measures. So some of the tools you're going to use with bleeding control are going to be tourniquets. It's obviously direct pressure, tourniquets, wound packing, compression dressings, and chest seals. Now with trauma care, some of the things we're thinking about here in the basic first aid level are going to be what's called C-spine, or cervical spine immobilization. It's basically putting our hands on somebody to help them from moving their neck in an exaggerated manner after they've experienced a traumatic event. So this, for an example, that 20-foot fall out of a tree onto the ground, we don't want that person just to jump up. We don't want to lift that person up and start moving that person. We want to protect their cervical neck because we're going to just assume at the outset here that there may be an injury to their cervical spine or the rest of their spine. So C-spine precautions. Other trauma care is going to be considering their airway, looking at MPAs, jaw thrusts. So I've adapted the March algorithm to basic first aid so that we can organize our tasks in a very traumatic situation. So starting off, M is going to be massive hemorrhage. Oh, I'm sorry, let me bounce back. That was March. So we're going to SE marches. So the S, once again, we finished up step 2 or box 2 with safety. And that safety was PPE or BSI, personal protective equipment, or body substance isolation, right? We're thinking gloves, eye protection, respiratory like a dust mask or an N95. Once again, just kind of keeping ourselves separate from any type of fluids or spit or blood or vomit. So we're going to start off step 3, box 3 with safety once again. First of all, is it safe enough for me to approach? We've already kind of covered that, but once again, this is a traumatic injury. Are we safe to put our hands on? And as I said in previous videos, nobody can tell you whether you should put those gloves on. I'm going to say you should. But if you don't have them, what is the line in the sand for you to put hands on and provide care for somebody if they're bleeding, experiencing life-threatening bleeding, or they're experiencing a life-threatening traumatic injury? That's up to you. But it is understood that we should put on some gloves. And along with the safety portion of SE marches, so we've got safety, and then right away is that C-spine. If we see somebody who's fallen out of a tree, been hit by a car, or suffered some sort of traumatic injury, we want to go right into that C-spine immobilization, which is something we go into in our courses and is something we need to take care of right away. Now E is going to be for expose. We're going to want to make sure we cut that shirt. We want to cut those pants. We want to expose from head to toe so we can see the injuries. We can identify bleeding. We can identify punctures, bruises, breaks, maybe minor bleeds that are identifying a more serious injury. So we've got our safety, we've got our expose, and M is going to be the same basic march that the military and fire departments use. So M is massive hemorrhage. Once again, we're looking at life-threatening bleeding here. We're looking at tourniquets, wound packing, compression dressings, chest seals. And once again, with that expose, if we haven't exposed, we may not be able to identify. We may see a lot of blood on somebody's arm, down in the forearm, wrist area. Maybe throw on a tourniquet 2 to 3 inches above that injury, but not over the joint. What we didn't do was expose this arm and realize they actually have another puncture up here, and they're bleeding from up here in the humerus area just above the elbow and from their forearm. So we put that tourniquet in the wrong spot. So massive hemorrhage, we're looking at that uncontrolled bleeding, implementing techniques and procedures and equipment to manage and stop that bleeding. A is going to be airway. Now in the basic first aid realm here, there's not a lot of airway devices we can use or that you can use to manage somebody's airway. What we're concerned with airway is, are they able to keep their tongue or any vomit from occluding or blocking their airway, so that which would stop them obviously from getting air from outside into their lungs and their lungs out. Some of those measures that we can use is if they've had a traumatic injury, a high level fall, say 20 feet, once we get that C-spine, we're holding their head in place, telling them not to move. We, at that point, if they're having trouble breathing, we don't want to just do a head tilt chin lift. We don't want to manipulate their neck once again, because they could have a cervical spine injury. So there are some other airway maneuvers we can use, which is called a jaw thrust. Also NPAs, or a nasopharyngeal airway. It's a small rubber tube, goes from the nose into basically their oropharynx, back in here into their neck, into their throat area, and it helps prevent the tongue from falling back. So if somebody's experienced a blunt traumatic injury, a fall, they may have a brain injury, or they may be decreasing their mental status to where they're unable to actually keep their tongue from falling back into their throat. So that NPA will then be inserted and hold their tongue out, hold their tongue a little bit forward so that they can breathe properly. Same thing as they may have blood in their mouth, they may have broken teeth, they may be vomiting. How do we manage that airway? How do we manage and keep their airway while keeping that C-spine in the position we found, or on their back, right? There's ways to roll the person and protect their neck to manage that airway. Those are things we want to consider. C is going to be, so MAR, so R's respirations, and we're looking at, once again, with that exposed, we want to make sure we've exposed their chest. So respirations, we're looking at that rate, rhythm, and quality. They're breathing too fast, too slow, too shallow, too deep. We're also looking for awkward movement in the chest. Maybe they broke some ribs on that 20-foot fall out of a tree. Maybe they had punctured their chest, and now we notice a hole in their chest, and we're seeing some bubbling and some minor bleeding. Once again, I said you may see minor bleeding, but it indicates a much larger injury that may be life-threatening. They have a hole in their chest, light bubbling. That's considered a sucking chest wound. We want to use that chest seal to cover that up. With respirations, then we have C for circulation. And for circulation within my family's first aid, the way we've adapted this, we're just looking at skin, color, temp, and condition. There's a saying in the medical field, skins don't lie. So we generally know on a given day, whether it's cold or warm, how we typically look if we're just kind of sitting around, right? Is our skin normal color, or is it not normal, right? Color, temp, right? Are we overly warm, overly cool, or cold? And conditions going to be sweating. Are we super sweaty, not sweaty? And remember, we're looking at environmental conditions to compare the injured person to the non-injured person. So with circulation, that's an indication that if we see skins that are different than ours, that injury that caused their skins, or that's causing that person to have, say, cool, pale, diaphoretic, or very sweaty skins after a 20-foot fall out of a tree, and they look cool, pale, and they're diaphoretic, that's an indication to us that this is trending on the more serious and possibly life-threatening side of trauma and injury. So H, so MSEMARCH, the H is going to be head injuries, and then I also have included, what we include is head, neck, and back, right? So we want to, maybe we blew through that C-spine, we didn't get that C-spine up in the S, right? And we're down in here, we're exposing, we're looking, we've got maybe some life-threatening bleeding, we put a tourniquet on, or we're controlling, and we get to H, right? Oh yeah, head. I want to evaluate some things on the heads. We're looking at pupils, we're looking at the airway. Maybe you forgot to check the airway. This is redundancy, and I've tried to build redundancy into the SE March's algorithm, because when you're inexperienced or not very, we'll just say inexperienced, it can be very overwhelming. Even for experienced people, it can be very overwhelming. So having some redundancy will help us so that we don't miss steps, right? So that we are preventing death, if possible, that we're preventing any further harm and reducing any pain. So with the head injuries, we're going to evaluate some things with the person's head. Once again, C-spine. Is somebody holding C-spine? Also our back. How do we check the back for injuries? If the person's on their stomach, how do we roll them, right? How did we get them over there? How do we check their back appropriately to check for any injuries, to check for any cervical spine tenderness, deformities? there's a process for that which we cover here. So once again, this algorithm, as I jump in here, once again, it's just helping you to organize your tasks and orient yourself to the tasks you need to accomplish to affect the best outcome for that person. So after we hit the H, we're going to look at the last 3 S's in the SE marches, and it's going to be shock. So with circulation, that's typically when we throw in the shock, when we're going to cover the person up, keep them warm, and treat for shock and recognize any shock symptoms. But once again, talking about that redundancy is that maybe you've had some experience and you covered that in circulation. Great. Maybe you blew right past it. Now we have shock is defined, because shock is the one of the top killers has a high probability of death when we enter into shock conditions, even though we've implemented all these procedures, right? It really leads to the lack of coagulation of blood and just decreased outcomes. So shock is very important that we treat. It's very important that we treat shock. So we go into shock treatment measures in that portion of the algorithm. And next is going to be my mind here. Secondary exams. So head injuries, then shock, and then secondary exams. So once again, redundancy, right? We've kind of moved through this algorithm. It's probably pretty stressful. A lot's going on. Somebody's in a lot of pain. It can be very overwhelming. We want to make sure we do a secondary exam, a head-to-toe exam. We want to check the interventions we've done, check any care that we've provided. We want to run through this algorithm verbally or through our mind once again, make sure we haven't missed anything. Maybe we did. Hey, let's improvise, adapt, overcome. Let's recover. If you miss something, you're doing the best you can. Now let's go ahead and step back and rectify that. Also, when we're doing our secondary exam, we're looking at the things that we've done, the care that we've provided. Is the patient or that person or those people, the things we've done, are they helping that situation, that person, to get better, stay the same, or get worse? Right? And if they're getting better, then we may be implementing things that are helping. Maybe things are changing. Maybe it's not as severe as we thought. If they're staying the same, then we need to just keep working that situation. Really what we're looking at here also is if they're getting worse. If they're continuing to deteriorate or they're getting worse and we've implemented these measures, we need to go back and really check these. Make sure we're working each one of these, right? So the exposed, the massive hemorrhage, the airway, circulation, respirations, head injury, hypothermia, shock, head, neck, back. We want to run those again and make sure that we've implemented the training that we've been afforded and the education that we've been given, with the understanding that sometimes we can give the best care, have the best training, and it just doesn't work out. So once again, this also feeds back into or goes back to that regret, right? You've stepped into this situation knowing that you've prepared accordingly, knowing that you're doing the best you can do. And when this resolves and everything's said and done, you can look yourself in the mirror knowing, hey, regardless of the outcome, I stepped in, I did the best I could. And if the outcome is tragic, the regret that comes with that by you intentionally deciding not to step in, or you intentionally deciding not to obtain the education and prepare yourself for that, can weigh on you for the rest of your life. So secondary exam is huge, right? And then lastly is situational awareness. Situational awareness, which we talked about in the video I'll link to up here, which is video 2 or step 2, box 2, situational awareness, actions, and safety. Once again, is just put your head up, open your eyes and ears, take a breath, and look around, right? At this point, we've already called 911, which we talk about back in the basics of first aid, and in video 2, once again linked to up here in our check 2, call 2, hands-on care. So right now with situational awareness is that, one, we may be in a somewhat dangerous situation, which once again you've evaluated whether it's safe for you to step in, right? And if you were in a tenuous position right here where it's maybe not as safe as it could be, or you may be in some form of danger but you've chosen to step in and help, reevaluate. Are conditions still the same, getting worse, or better? Maybe you're at a park. Few kids were mauled by a dog, right? Bleeding control. Is that dog still out here? Do we have somebody taking care of that possible threat? Situational awareness, looking around, gathering information with our senses, and making a decision. At the same time, 911 has been called. You're going to start to pay attention. Where are they approaching from? If we're at a park and we're far on the other side of that park and the parking lot or the entrance is far away from us, we at this point or earlier can send people to that park entrance. We can send people to EMS, or maybe make another phone call to say, hey, I see the fire trucks, they're on the wrong street. I see the ambulance, they're at the parking lot. And you can locate them or walk them into where you are. So In closing, step 3 is simply just a box of tasks that I use to orient myself when I was professionally working as a firefighter, to organize my tasks needed in a traumatic situation, a bleeding, life-threatening bleeding type situation, so that I knew that the training, the education, and the equipment I had was being fully utilized for that situation to affect the best outcome for that person. Now adapting it for you and for my family's first aid, we've got the box 3 or step 3, SE marches. So safety, C spine, E expose, M massive hemorrhage, A airway, R respirations, C circulation, H head, neck, and back injury, hypothermia, S shock, S secondary exam, and your last S is situational awareness. So hope this has helped you guys out. Please click the subscribe button, hit the notification bell, leave a comment down below. We are going to be making these classes online so you can at least academically get some of this information, and then go out there and find somebody who can provide that training if we can't. I hope you guys have a great day. Take care.